Before we get into today's lecture, I want to talk a little bit about some possible changes for next year, so stay tuned. We may have some changes in the time. We may change the name, so be on the lookout in your emails over the course of So over the course of this year, we heard from a range of speakers on a range of topics of global, national, and local importance. We had a symposium about the Ebola epidemic, heard about trauma care in Boston and Haiti, conflicts between faith and medicine, and the future of public health and a post-Affordable Care Act law. We learned about firearm violence and looked closely at the inner workings of our own local health department. And now we are privileged to end our year hearing from our own dean, Dr. Diez. Dr. Diez is internationally known for research on the social determinants of population health and the study of how neighborhoods affect health. Her research areas include social epidemiology and health disparities, environmental health effects, urban health, psychosocial factors, health, cardiovascular disease, and use of multi-level methods. This September, under the Dean's leadership, we will be hosting a symposium here at the school entitled Reimagining Health in Cities, New Directions in Urban Health Research and Action, bringing together researchers, practitioners, and policymakers focused on health in U.S. cities, in the U.S. and worldwide. So this afternoon serves as a teaser of sorts, as Dr. Diez will share with us some of the most important issues to consider about the future of urban health and how we as public health practitioners can be involved in developing solutions to address the health issues of those living in our urban environment.
Okay, good afternoon. Can you hear me okay?
Yeah,
Yes?
but the lights, they're gonna fix the lights.
They're gonna dim the lights, yeah. But is the mic on? Yeah? No?
No.
It makes sense. I have to hold it?
Yeah.
Okay. Can I hold this one, or can I hold the other one? This one? Should she use this one? Can I use that one? You could try it. Well, does it have to be this dark, or I'm gonna fall asleep? A little bit lighter? All right. How about that? You don't have any intermittent? The front, dim the front. Okay, that's a little better. Okay. So thank you for coming. So today I'm going to give you a little bit of an overview of some thinking around health in cities. And I'm going to do a few different things. I'm going to start by talking a little bit about the growth of cities worldwide and the potential health implications of urban living. I'm going to mention some challenges and also opportunities for public health in this context. And then towards the end, I'm going to spend a few minutes talking a little bit about the role of our school and some of the things we're already doing, some of the things we might want to do as a way to start the conversation around this topic. So I'm going to start by talking about the growth of cities worldwide and the health implications of urban living. And I'm going to do this with three propositions. And the first proposition will not be news to any of you, and that is, well, maybe it will be, I don't know. The proposition is that the future of humanities will largely be in cities. And why do I say this? Well, if we look at data on urbanization levels, and this is data from the UN, pretty recent data, we can see that, well, overall, over half of the world's population lives in cities. Of course, the levels of urbanization differ a lot across regions, as you can see here. They're lower in Africa, they're highest in Europe, in Latin America, and in North America. But they're increasing all over the world. And in fact, the rate of increase is fastest in the countries of Africa and Asia, as you can see in this figure. And if we look at these are rates, sorry, this is a little bit small, but these are the percentage increase, annual rates of change. Although the population as a whole is increasing at a smaller rate over time, and that's why you see these lines going down, the rate of increase in the urban population, if you could see these numbers, you'd see they go from 0 to 4%, and here from 0 to 2%. So the rate of increase in the urban population is about twice as fast as it is in the rural population. And you can also see how Africa is the area where the rate of increase in the urban population is the largest. So if we look at the share of the world's population growth across urban and rural areas in less developed and more developed countries, a very interesting fact is that between 2000 and during the first 25 years of this century, 90% of the increase in the world's population will occur in urban areas of less developed countries. So the urbanization is a very important phenomenon all over the world. And this is again, the increase in the world's urban population you see remarkably fast increase in developed countries, also increasing in developed countries, although not as quickly. So this is what leads to statements like this by the UN during a State of the Cities initiative. It says, for better or for worse, the development of contemporary societies will depend largely on understanding and managing the growth of cities. The city will increasingly become the testbed for the adequacy of political institutions, for the performance of government agencies, and for the effectiveness of programs to combat social exclusion, to protect and repair the environment, and to promote human development, and I would add to promote human health as well. Proposition 2. The health implications of city living are actually variable and malleable. Let's think about what the correlates of city living are, if we think in generic sense. Well, obviously the biggest defining feature is higher population density, more people living together on less space. This leads to more intense and potentially qualitatively different social interactions, and this may have a number of implications. Concentration of economic assets. Many economic assets and economic activities are concentrated in cities or around cities. Cities are also hubs for innovation and creativity. That's why I love cities. That's why I moved back to a city from a little town in the Midwest. In addition, because of the higher density, there's higher and more concentrated need for services, housing, social, education, and health services. Environmental hazards also become more concentrated and magnified potentially. Air pollution, people, cars, air pollution, urban heat, and others potentially related to industries around cities, for example. Cities are also incredibly diverse in race and ethnicity and in national origin, and this also creates a social dynamic which is important for health in many ways, as we'll discuss. And it also leads to big social inequalities in close geographic proximity. So I'm sure you're starting to think about, well, how are these things going to affect health? And obviously many of these things can affect health in many different ways, some for better and some for worse. So what are some of the possible health consequences of city living? Well, let's start with some of the minuses. Adverse classic environmental exposures, potentially inadequate sanitation. This happens in many cities of the developing world, where access to sanitation is a basic, continuing problem. Air pollution, industrial exposures, poor housing. Physical environment effects on behaviors, aspects of urban design which are not conducive to healthy living, features related to the mass production and distribution of foods, which results in the consumption of unhealthy foods, fast foods, processed foods. Advertising is also concentrated in cities, advertising of products which may not be healthy. Social stressors, conflict, violence, discrimination, all these things can also concentrate in cities because of the different kinds of social interactions and because of the density and the lots of people living together in close proximity and in very different, often social circumstances. And potentially limitations in access to services as a result of density and the inability of the government, for example, to provide necessary services for a number of political, social, and economic reasons. But there are also, and again, social inequalities and spatial segregation, which also leads to unequal distribution of many things which we know are health-related. So magnified health inequalities, potentially. Now, there are also pluses of city living, potentially. So we can do things in cities because we have a lot of people living together. Urban policies, for example, can have a big impact on health, simply by the sheer density of cities. Potential for better access to services as a result of proximity and greater availability. So for many people, migrants, why do people move to cities? Because they can get jobs, and often because they can get more services. If you look at what lots of people do, usually there's a good reason behind what they're doing. There's also the potential for positive social interactions in cities, for cohesion, for support, for people banding together, for advocacy, which we know have beneficial health effects. And again, creativity, social interaction may themselves be health enhancing. So the bottom line, as you can see from here, is that there are ways in which cities can be good for health and ways in which they can be bad for health. And I think that's really important and interesting because it means that there's a lot that we can do to make cities healthy and to make cities have the potential that they can have for enhancing the human development. Third proposition, well, the principles and challenges of the approach that's now called the population health approach apply, I would argue, especially to cities. And what do we mean by this population health approach? Well, we mean an approach that really thinks about factors at multiple levels as affecting health, all the way from policies and how society is organized and social inequality to neighborhood conditions, to individuals, to their biology. Integration of social and biological processes, need for policies outside the healthcare system to substantially impact health, and an explicit need to focus on understanding the reasons for health inequalities, because they can tell us a lot about the drivers of health generally, and because we can't improve levels of population health if we don't address the causes of health inequalities. So all of this obviously applies to health in general, but certainly to understanding urban health. And you see this kind of multi-level approach in the broad sense reflected in conceptual models of urban health. This is one, which is actually adapted from a model by Galea Blahov and Freudenberg several years ago. This is from the WHO Kobe Center on Health in Cities. And it emphasizes certain aspects that they're interested on, but certainly things at different levels. And this is another example from an urban planning approach. And you can see that it also has this idea of multiple kind of nested systems as affecting health. So if we want to change health in cities, we have to think about how to be able to understand the actions, the effects, and how to be able to intervene on various levels. So what do we know about health in cities? What do we really know? Well, it turns out there's remarkably little consensus on whether city living is good or bad for health. And the answer is likely it depends. It depends what outcomes we look at. It depends what context the city is in. So there's no single answer. Is city living good or bad? Which is also, again, interesting because it means there's potential there. It's also true, though, that many population health problems are starker or become magnified in the context of cities simply as a result of the greater population density of cities. So even if cities are not, on average, less healthy than rural areas in a particular context, because there are lots of people in cities, because there are lots of inequalities within cities, many health problems are magnified or starker. And again, there's enormous heterogeneity within cities. And we'll talk a little bit more about the heterogeneity in social circumstances that are related, and in ethnic background, et cetera, that are strongly related to health. So large health inequalities. So, and again, there are, of course, opportunities to influence the health of many through policy. So I'm going to show you some data from the US. Of course, if I had data in another country, the patterns might be pretty different. Because I thought it was interesting. This is pretty recent data. It's 2014 update from the Rural Urban Health Chart Book. And I'm sorry, I'm sure you can't read this, but basically they classified counties in the US as in various levels, in 5 levels. And I'll just read this out to you. So these are metropolitan counties, large central, large fringe, small metro. And these are the more rural or non-metropolitan counties. They call them micropolitan and non-core. And just to give you a sense, about 17% of the US population falls into the rural areas, and the remainder falls into the urban areas, which is consistent with what we know about urbanization in the US. And so I'm going to show you some data on how various things different things vary according to these levels of urbanization. So this is just some demographic data, which is nice to start with. So from left to right, these are those 5 categories. A, B, and C are the metropolitan counties, and D and E are the non-metropolitan counties. So these are more urban places, and these are more rural places. And the degree of urbanization increases from right to left, or the rurality increases, urbanization decreases from left to right. So you can see here that urban areas tend to be younger, quite a bit younger. The composition of the population becomes older. The proportion of the population over 65 increases in a very monotonic fashion, which is actually quite interesting, as the level of urbanization decreases. Urban areas are also a lot more diverse, as you can see here. The race and ethnic composition also becomes increasingly homogeneous as the level of urbanization decreases. This is poverty levels. And what you can see here is that these are the core metropolitan areas, higher levels of poverty. They drop in these peripheral, the large fringe areas. These are probably like wealthier suburban areas. And then they increase once again as rurality increases. And you'll see this pattern repeated in some of the other data I'm going to show you, actually, which is interesting. So what about some health measures? I'll read these out to you because I know they're small. So these are cigarette smoking. This report pulls together data from many different sources, many different surveys, etc. So this is cigarette smoking actually is higher in rural than urban areas, in both men and women. Alcohol, consumption of 5 or more alcoholic drinks is not that different. I'm going to go through these quickly because I don't want to spend a lot of time on them. But this is obesity. Obesity also increases as urbanization decreases in the U.S. Physical inactivity has a little, small, this is the percent of people who are physically inactive, little increase in the core urban areas, less physical activity, and then it drops, a little more activity in the fringe metropolitan areas, and then inactivity increases with increasing rurality. And this is a major depressive episode, and you can see increasing depression as urbanization decreases, but then a drop in the most rural areas. Whether that means something or not, I don't know. These numbers start to get small out here. Infant mortality follows a pattern that's very similar to the poverty pattern that I showed you. And these are death rates for all causes among adults 1 to 24 years. And you see, actually, these are age adjusted, so the age factor is taken out. And you can see increasing mortality rates in more rural areas. These is death rates for adults 25 to 64, a similar kind of pattern, this drop in these kind of suburban areas, and then an increase. And these are death rates for all causes among people over 65. So you see that urban areas don't do that badly on all indicators. There are, the core metropolitan areas are certainly different than some of the other urban areas. Ischemic heart disease increase is a little higher in the core urban areas, and then has this kind of U shape that we've seen before. And these are homicide rates, and as you can see, particularly in men, much higher levels in the core urban areas than in more rural areas. And I think this is the last figure that I have on this. I wanted to look at something related to healthcare access. So this is no health insurance coverage, and this is all counties in the red, all incomes in the red. And these are lower income and higher income people. But so you can see again this little U shape, which mirrors the poverty distribution that we saw before. And the supply of physicians, active physicians per 100,000, decreases obviously in rural areas. So obviously a lot more physicians per capita in urban areas than in the rural areas. So these are some descriptive indicators which I thought were interesting to look at, because we don't usually look at big picture data like this. Now, there's enormous heterogeneity within cities. So these patterns that I showed you, of course, are highly variable. And this is just one example. These are firearm homicides per 100,000. And they're shown for different cities. And beside the name of the city, they put the name of the country that has a similar homicide rate to just show how some of the variability across cities reflects variability across countries. So large variability across cities. Not all urban areas are the same. So those patterns that I showed you are probably hiding a lot of heterogeneity. Cities are more unequal also. These are the ratio of the 95th to the 20th percentile of the income distribution. It's about 10.8 in the 50 largest cities and a bit lower, about 9 in the rest of the US. But even then, there's a lot of differences across cities in the degree of income inequality. And I'm showing you this just to highlight the idea, well, maybe we should be looking at how all these things that differ across cities are affecting differences in health across cities and differences in inequalities in health within cities. And the changes over time in the degrees of inequality, this is from the Brookings report, quite interesting actually. The differences over time in the degree of inequality across cities also varies dramatically. So these things are changing. This is an opportunity for us to try to understand how these things are affecting health in cities. Health also varies enormously within cities. These are some maps that the Robert Wood Johnson has supported. You probably can't see it in the back there, I'm sorry, but they're different cities, and they show how life expectancy varies across different subway stations or different locations in the city. And you can see very large differences in many of these cities. For example, this is Washington, I think, from the shape of the metro. Washington. You can see 84-year life expectancy here and 77 here. So that's a 7-year life expectancy. It's a big difference in a small geographic space. I mean, this has been replicated for many different cities. So we should do that for Philadelphia later. This is another example of even more smaller scale variation. This is the city of Chicago. This is data from a study that I worked with a few years ago called the Chicago Study of Adult Health. And this shows, using survey data, there are ways that we'll talk about a little bit, that you can get estimates for small areas. So these are Chicago census tracts, and these are variations in the prevalence of hypertension and also in CSD score, which is a scale to characterize depressive symptoms. So enormous differences in the prevalence of hypertension, from under 25% to over 75% prevalence in some geographic areas. So very large heterogeneity in many other health outcomes as well. So given these patterns and these kind of ideas about how city living may affect health, and some of the data that we have, what are some opportunities for public health? And of course, this is my list. I'm sure I'm interested in other ideas. I'm sure you'll have other ideas about opportunities and challenges for public health in cities. But I've grouped them into 3 categories. One has to do with a very simple and yet very important thing, which is information and description. Why? Because that leads to awareness, and because awareness is necessary for action. So how does health vary across and within cities? And I would argue that we don't have a lot of information on that. In fact, in looking for data to show you today, I had to look quite a bit to find data. There's an odd study here and there that does an urban-rural comparison, but it's one little study here, and it's not clear if it's generalizable. There's not a lot of, I was unable to find a lot of good information. And also there's a lot that can be done in terms of small area variation within cities, and we'll talk about that. The second big opportunity has to do with causal inference, in the sense of drawing inferences about what the drivers of these differences are. What are the causes? What are the causes of differences between cities and differences within cities? And this is obviously important. And I think we have to really look at both. We have to look at both. We have to look at between city and within city differences. Because city level factors may affect both. And then, of course, variation within neighborhoods within a city will also affect patterns within cities. And we need causal understanding of these things because that, to identify actions and policies that are going to work, because a prerequisite for something to work is that you're intervening on some causal mechanism. And finally, obviously, last but not least, translation. So what works to make these changes, and how do we get it done? How do we make it happen? So I want to talk a little bit about each of these and give you some examples. So information and description. I think there's a lot of potential for public health in thinking about how a variety of new sources of data that are increasingly becoming available could be used to better describe health in cities. And this includes, the whole smart cities movement, which is really about digital technology embedded across city functions, and I'll show you an example of that. Geographically linked electronic health records, and social media and mobile devices. So let me give you a few examples. This is an initiative that IBM has for smarter cities, which is really about helping cities, supporting cities to generate and compile all sorts of data about things that they do. Now, some of this data you say, well, is it relevant to public health? And a lot of it may not be, but some of it may. And so I think we have to start thinking about learning more about what this data is. This is so-called big data, although now everything is big data. The neighborhood stuff that I used to do is now called big data, which I find incredible, but whatever. I say, sure, yeah, we do big data. Thinking about how we can, learn more about what data is available and how we can use it. Now, the key thing here is making meaningful use of this stuff. So it's not just about more and more data, because more and more data without extracting any meaning from it is, not helpful. But another area is this idea of digital health records, electronic health records. And I was on a committee last year that put out a couple of reports, an IOM committee, about capturing social and behavioral domains in electronic health records. And one of the things that was recommended was the routine geocoding of all electronic health records. And so, there are many places are starting to do that now. This is called geomedicine. And thinking about, well, what kinds of things could we learn from geographically referenced electronic health records. And this is just one example. This is a report put out by the Children's National Medical Center in Washington, D.C. Very simple, but done with electronic health records from this children's hospital. And this figure on the left simply shows pediatric primary vaccine completion. The colors indicate a higher completion rate across Washington, and mapped together with provider availability. And so even just that kind of information can be useful and enlightening. This is another one, distribution of burn cases by neighborhoods in Washington, and they actually found that over half of the burns in kids are a big problem, of course, and over half of the burns were concentrated in just 6 neighborhoods, for example, which already indicates potential for intervention. So many other things, we are working with DUHOC here to try to create some capacity for geocoding of electronic health records and begin to do some things along those lines. Another thing is social media, the famous Twitter. I'm not a social media person. I guess maybe I should be, but I'm not yet. But this is a study done by some urban planning folks where they mapped tweets in Louisville, and they knew where the person lived, and they mapped where they were tweeting. And so it gives you an idea of people's mobility, where people are going within the city. So these are odds ratios of tweets. So the east end is kind of the wealthier, whiter area, and the west end is the poor, predominantly black area. So this shows you, where people are tweeting, and you can see that the east end people are, of course, primarily tweeting, in the areas where they live, but there are also some out here and vice versa. Now, you say, well, yeah, that's nice, but what does it tell me? So, of course, we have to think about what the potential of this could be for health. But this data is out there, and it's being used increasingly. They also then looked at what the tweets said, and this is an example, potentially not, well, there might be some relevance to health here, but they looked at tweets that used the word ghetto. And then they mapped where they occurred and what people were saying. And so they do a sociological analysis of some of this data to try to understand mobility and people's perceptions of the areas that they're in, etc. Now, what about for health? There's a growing movement to use this kind of data for health. This is actually a figure showing predictions of the influenza rate from, as measured by the CDC flu data, and by a system that some folks at Hopkins, actually he's coming to our Urban Health Symposium, developed to use analysis of words to identify cases of different health-related things. And they really were able to mimic, to reproduce the actual influenza data very nicely. And they're starting to look at other health conditions and finding some correlations between the data from the Twitter data and other survey data. So there's some potential there for things that could be done in urban health in terms of characterizing health variations in health within cities. Potentially combining this data with other data sources, not just this data, obviously. And a methodological area, I think, which is very interesting, is to think about, well, how could we use this data together with survey, traditional survey data or mortality data to get better estimates for small areas? And there are a number of ways that we can do this. This is one example, looking at variations in smoking prevalence in Los Angeles that actually combines different kinds of surveys and combines information about the characteristics of areas to derive improved estimates for a given area. And so this is a technique that can be used to improve description of variability in health within cities as well. This is just an example of a report from Santa Monica that actually does a lot of this, pulls a lot of this together to describe health in Santa Monica. So information description. The second big area that I wanted to talk about has to do with causal inferences. So drawing inferences about causes, of course. And certainly, I think there's a lot more that can be done with observational studies. And perhaps even, as far as I know, there haven't really been observational studies targeted at understanding health in cities. And particularly because, in cities, because we have this clustering, the idea that many, quote, exposures may be acting synergistically from classic environmental hazards to social stressors to other things. How do they really act synergistically to affect health? And so I think there's an opportunity to do that in terms of observational studies. And as I said before, cross-city comparisons. Some of you may have heard of this Keys 7-country study, which was a very famous study of cardiovascular disease from which we learned a lot about the cause of cardiovascular disease that had cohorts in different countries. So imagine an observational study with cohorts in different cities, what we could learn about drivers of health across and within cities. And this is actually an example, you doing an analysis from existing data from several European cities and looking at how mortality varies remarkably across cities, and also how the degree of the mortality, the inequality in mortality, these are mortality rate ratios comparing the first and the fourth quartile of social deprivation, also is heterogeneous across cities. So once we see that, then that raises a whole bunch of questions about, well, why? Why do some cities have less health inequality than others? And that can shed light on what we can do to reduce health inequalities. And I think there's a lot more that can be done in this area, certainly in the U.S. A third area for causal inference has to do with natural experiments and evaluation of action. So taking advantages of changes that are occurring that mimic experiments, or actions that are taken sometimes for reasons that have to do with their potential health benefits, even in the face of incomplete evidence, because that's what we have to do in public health, or actions that are taken, policies that are taken for reasons that have nothing to do with health, but that could have health implications. And so by linking novel data, and because a lot of the times the challenge in these studies is that we don't have data, we don't have the before and after data, we don't have the before data. And so if we're characterizing the health of cities in a kind of continuous fashion, when something happens, we'll be in a great position to be able to evaluate that in a much more rigorous way and learn from that. So, I don't know if any of you recognize this map. This is Jon Snow, right, the broad steep puffs. So this is pretty much one of the, an early natural experiment, right? But of course there are lots of other, this is just about, evaluating access to water and how it varies within a city and its health impact. I think it's also, interesting to think about how we can use the natural experiment approach to look at the health impact of things like neighborhood regeneration. And this is an example from a study in Glasgow, where there's a Medical Research Council has a research unit there in Glasgow that Sally McIntyre directed. Some of you may know her name, very well-known sociologist who did a lot of health stuff, very good health stuff, and neighborhoods and health, and gender and health, and social inequalities in health. And so they partnered with this neighborhood regeneration program to evaluate the health impacts. And so I think that's also a very interesting and important area for us to think about. And finally, in terms of causal inference, also thinking about, is there something that we can learn from, that we can bring to bear on our understanding of causes and how policies might or might not work from systems thinking and systems approaches. There's a long history of thinking about systems in cities, cities as systems. This is a book from 1969, Urban Dynamics. Jay Forrester is a little bit like the grandfather or the great-grandfather or whatever of systems thinking. And he applied his thinking to cities. This is a much more recent book by Michael Batty in the UK, The New Science of Cities. And so this purports that cities are really complex systems, and can some of the tools that we can use to understand the functioning of complex systems help us understand some of the drivers of health in cities. And this is an example of an attempt to capture some of the relationships between the built environment and public health in a type of systems diagram called the causal loop diagram. And you can't read this, but this highlights these feedbacks and interrelationships between various domains. And so there are various kinds of simulation and modeling techniques can be brought to bear to understand the implications of some of these relationships. Of course, this can be a lot more complicated. It can get out of control. And so obviously we're not going to get into details of this, but there are lots of challenges with this approach as well. But this, you can't read it, but this is actually putting together various different subsystems. But it's kind of cool to think about it. This is actually a paper that tried to come up with a model of health in Toronto. I think it was Toronto. It doesn't say here, and so they actually simulated. They came up with a conceptual model using a variety of different domains and relationships between them, and they had several areas of potential intervention that they were interested in. So they simulated this system, and then they looked at the hypothetical impact of different kinds of interventions on the system. And so, of course, there are lots of caveats to this, but I'm showing it to you just, because I think it's interesting to think about cities as systems. And are there some things that we can learn from using some of the systems approaches to understand the dynamics of health in cities? And this is also interesting, not so much from getting a very specific prediction about what would happen, but because when you start to try to draw this, and particularly if you draw this with other people, and you draw this with communities and with stakeholders, you can really start to talk about what some of the processes might be. And that all of a sudden can open up to a whole bunch of new questions that you hadn't even thought about that need to be pursued using qualitative approaches or quantitative approaches. So it kind of opens up your mind to think, because these things obviously, they work like this, right? It's not like a cause and effect. They're dynamics, they're feedbacks, they're things influencing each other. So it makes a lot of sense to think about that, even if it's just conceptually and we're not interested in the very fancy mathematical modeling of this stuff. And so this is a quote which I like from Louise Betancourt, who is a physicist who does urban systems, very abstract stuff. But so he says cities as integrated social networks embedded in space and time. I thought that was really, really cool. I mean, think of a city as a social network. Really, it's a really big network. We're all kind of connected in the city, and we're embedded in a certain space and a certain time. And so he says cities are not only complex adaptive systems, but also a particular and unique type of system, a new organizational invention that can combine and amplify the cognitive abilities of humans and generate open-ended socioeconomic development. So it's kind of interesting to think about that and what the health implications of that could be. Okay, and last but not least, translation. So here there are a number of very important questions. So what kind of evidence is most useful to motivate action in cities? I mean, just many of these will be very basic questions, but I think they're still important. How should this information be presented? How should it be used? What's the most effective way to translate it? What other non-evidence factors, because we know there are tons of them, what other non-evidence factors are important in whether a policy is implemented in a city? And what can we learn about the evidence policy process from cross-city comparisons? So these are all, I think, important questions that can be addressed with quantitative or qualitative or historical approaches that I think are also very important opportunities for understanding health in cities. Okay, in the last few minutes, I want to talk a little bit about urban health and our school. So this is our mission, updated mission statement that we've incorporated into the updated strategic plan. And you can see this idea of have a special commitment to improving health in cities, eliminating health disparities, and promoting health in all policies. So all certainly thinking about urban health is a very important component of the mission of our school, and these sort of three interrelated areas: urban systems, social justice, and health disparities in policy and practice. So what are some of the things that we could think about together in terms of moving this urban health agenda forward at our school? And these are, obviously these are my ideas, and they're suggestions for us to start to think about. But certainly, what are some of the big questions in terms of health in cities? What are the big problems? Starting with a Philadelphia focus, but also thinking about national and global projection. Looking as well at within city, both, as I've said before, both within city and between neighborhood, and also across city comparisons. I think we can learn a lot from looking across cities. Of course, the data issues, comparability is always an issue, but I think it's an important opportunity. Methodological resources. How can we improve the infrastructure that we have and our ability to work with data on cities, to measure things about health in cities, and to analyze that data? So increasing our capacity in those areas, in the methodological resources, which are very important. Combining this with a historical and qualitative approach to understanding the development of city living and its health implications. I think that's really interesting to think about. What kinds of urbanization, what are the features of good urbanization for health and bad urbanization for health? Even conceptually, in an abstract way. How has this played out historically as cities grow and change and develop? There's a lot that we could learn from that, I think, as well. And also thinking about novel approaches to engaging communities and policymakers in issues around urban health. I mean, are some of these new data sources, are they going to capture people differently than the same old stuff? Or are there ways that we can present that data in a way that's motivating and challenging and mobilizing that we haven't been able to do up to now? So these are some ideas. And certainly thinking about our educational programs, areas of concentration that are relevant to health in cities, potentially developing a summer program that's related to urban health, and a broad array of methods and approaches that are relevant to it as well. So these are just some research areas. These are my of course this is colored a lot by my interests, but using novel data, geographically linked electronic health records, social media, mobile phone data, and methods such as small area estimation to characterize variation in health in cities. Leveraging this description for community empowerment and policymaker engagement. How could we do that? This idea of clustering of adverse exposures and their causal contributions to health disparities. That's an area people talk about, this cumulative risk, this clustering. EPA is very interested in it, but nobody really does it right. Nobody really knows how to do it. How do we look at the fact that there's this adverse clustering of a number of things that are health related, and what are the implications of that for health, and what interventions would work the best in those contexts? As I mentioned, health implications of community development and neighborhood renewal. Intersectoral partnerships to improve health in cities. So the health system partnered with social service, lots of interest in that now in terms of thinking about even just adding social information to the electronic health records. What could physicians do with that information? What kinds of referrals could they make? this idea of prescribing social services, for example, so linking social service and the health system, and also different ways in which the health system and public health could be linked in ways that they haven't been as much in the past. And cross-city comparisons, as I've said before. Now, one component of this that I want to talk about is something that I mentioned to the school when I first arrived, and I want to give you a little update on it. We will be talking a lot more about this, but this idea of creating here at Drexel, a Drexel Urban Health Observatory and Collaborative. This is kind of a tentative name for now. It's very long, but that's what it is for now. And so what would be the mission of this initiative here? And the mission is not very complicated. It's to improve health in cities by increasing scientific knowledge and public awareness of health and health variation within cities, and by identifying and promoting effective actions and policies that improve health and eliminate health inequalities in cities. And these are some of the objectives. To use innovative data and approaches to characterize and monitor health in cities. You'll see a lot of these themes reflected in what I talked about today. Conduct research on the drivers of health in cities and health inequalities within cities. Promote the translation of evidence into community action and policy. Support training and capacity building in global urban public health for students, community members, and policymakers. And promote exchange and mutual learning across cities through exchange of faculty and students, collaborative research, and joint dissemination and advocacy activities. So this is the grand plan. And some of the principles are this idea of data for action, place-based approaches, focus on health disparities, and community engagement policy translation. I think this is very consistent with what I think is going on at the school already. So it's a way of kind of trying to tie this together and giving it even more prominence. So activities to date. So some of you have seen a little draft proposal of some of these ideas, and we're starting to get input from various people, and we'll be talking about this more. We're starting to assemble a core infrastructure team. We have a project coordinator who is Katie, who's right here, Katie Livingood, and Steve Melly, who's our GIS specialist. Steve here, there's Steve. And statistical and data support, Carrie Moore. Is Carrie here? And so some of this is currently, in transition between various other grants projects, and gradually, as we grow this initiative, we'll be applying for new grants to support a lot of this activity. So, yeah, among the activities that we've been organizing this Urban Health Symposium, and we're starting to scope out data availability for the Philadelphia region on health determinants and outcomes, and we'll be talking about that more another time. And also to begin to build research partnerships around selected topics. And so, we hope in next steps to start to promote the use of Philadelphia data through various pilot studies, which we'll be telling you more about, continue to build collaborations around related grant proposals, further develop the core infrastructure, and start to think about training activities around urban health. So we hope, some of this, I'm sure many of you will be involved with this, and we'll talk a lot more about this, but I did want to give you a little bit of an update, since I had mentioned this, I guess about a year ago, a little more than a year ago, when I first came. So to finish up, this is a statement from the Healthy Cities movement at the WHO, which is old now, but I think it's still, when I saw it, I thought it captured a lot of the way I think about cities, and I think the way the school really thinks about health and health in cities. So a healthy city is one that is continually creating and improving those physical and social environments and expanding those community resources which enable people to mutually support each other in performing the functions of life and developing to their maximum potential. And this approach places health high on the agendas of decision makers and promotes comprehensive local strategies for health protection and sustainable development. Basic features include community participation, empowerment, intersectoral partnerships, and participant equity. So this to me reflects a lot of the kind of themes, the way I think about urban health. And so I thought I'd share that quote with you to finish off. And so thank you for your attention, and I look forward to your comments and questions. We can turn on the lights, maybe.
I have a question.
Yeah.
It was a very eloquent speech. I've never heard it before, so I messages and capturing those data points and getting into those, whatever they are tweeting, isn't that infringing on privacy rights?
That's a very interesting question. There's a lot of debate actually on the ethical implications of using the Twitter data. And there are a bunch of papers on that. So I think it's something that we have to really think about if we start to use that data more. Yeah. It's a very important issue, so I'm glad you brought it up.
So I know that this presentation was just generally looking at, the health in cities, but do you think also another factor could be the gender of these different populations? So it might be, because I'm from the Washington, D.C. area, so when you pulled up that map, that makes perfect sense, but could it be that, there are more women living up there, there are more males, or the age demographics or anything like that? Has your research shown you anything of support or refuting against those?
Well, I mean, when people look at variations in health within cities, across neighborhoods, they're accounting for the fact that there may be differences in age and in gender, because these are, of course, very strongly related to health. And so you want to make sure that you're accounting for those differences. You're not just picking up differences in the distribution of people by age and gender.
Oh.
There was one study that you had mentioned that looked at creating better proxies for neighborhoods and pooling information from various sources.
Yeah.
And so what are the implications, especially when you consider the way, say for instance, one city may collect data versus another city, especially if you're looking at cross-city analyses?
Yeah, I think, for cross-city comparisons, I mean, there'd be a whole host of methodologic issues, right? If you're pulling together different kinds of data. But it's a very interesting question in terms of, how, we usually think about, a survey is one thing, this survey is just the survey, we can't combine it with anything else. But in fact, there's all this overlapping data that's getting at the same core things. And so are there ways that we can use that data, combine it more effectively?
That for me to figure out?
Yeah. Yeah.
Are you aware of any research that has looked at kind of the role of cities across the life course? So you know what it means if you're in a city when you're a child, and then you move to the suburbs, and maybe you move back to the city when you're older.
Yeah.
Have people looked at that sort of stuff?
I haven't seen that. I mean, there might be people who've looked at that. I think that's a very interesting dimension to think about, kind of the life course effects. Yeah, that's a very interesting question. Yeah. I haven't seen any data on it. There might be, but I haven't.
Some of the, I really liked what you were saying, and the question sort of is towards the future. We know that there's certain things that we already have knowledge of about the health of cities and what make healthier cities. And I see that in this country at least, there's a very conservative and strong group, maybe large, that is uninterested in funding or allocating the funds for making the infrastructure or other kinds of changes that we already know might be helpful. The question I really have is how do we as a school address that so that our data collection and our data gathering and our studies don't end up being very nice additional information, but ignored information?
Well, that's our job, right? That's a hard question, and I think. Well, I think there are a number of. I mean, I can give you a few reactions, and I'd be interested in what other people think. I mean, I think first of all, we have to try to answer important and meaningful questions, and we have to present those answers in ways that are compelling and that are clear, and that are understandable. And even that in itself, and sometimes it's just showing an old problem in a new light, right? I sometimes mention this as just from my own personal experience. So when I started doing this stuff on neighborhoods and cardiovascular disease, it was not very common, and actually I was surprised because I got a lot of very positive reception because people were like, oh, it's the neighborhood. I hadn't thought about that. So they were very used to thinking about poverty, but that was like, these poor people, they're just doing the wrong things. Of course they have more, of course they have more. But when you started to frame it as the neighborhood, all of a sudden it was different. It was like looking at it slightly differently. And so I think there are sometimes things that we can do with data that have that kind of effect. And that can be incredibly transformative. So it's not just showing the same, this stuff showing the life expectancy across the subway. Now we've seen many of these maps, so everybody talks about it, everyone's seen it. But the first time you see it, you say, oh yeah, wow. Two metro stops, life expectancy drops by 5 years. What's going on? This is not acceptable, We have to do something about it. So there are things about the kinds of questions that we ask, how we show data, how we show information, how we communicate, which are very important. Of course, as citizens, there are other things that we can do that have to do with transform, we're not going to have change just by showing data, obviously. It's a piece of it. So there are other things that we have to do that have to do with, advocacy as public health practitioners and then just as citizens, in terms of the things that we can advocate and the ways that we can try to make change in society. So it's a big question. I think as a school of public health, we have the responsibility for asking important questions and for providing the right answers to those questions and for communicating that information in a way that is transparent and clear and compelling. And obviously to partner with policymakers and communities to help them leverage and use that information. We can certainly also advocate ourselves on the basis of the information that we have. We have the responsibility to do that, I think. What else? Yes.
This is one question. With the ACA, hospitals are now empowered, encouraged, whatever, to do these community health assessments. Do you see anything on the horizon where hospitals, which heretofore have been pretty, hold their data to their chest, do you see their data becoming part of the repository of data that we can use to look at health in cities?
Well, I'm sure other people here will be better qualified to answer that than me in terms of the specifics of it. I think it's good. I think there is, with all this talk of population health in the context of healthcare reform, and the fact that hospitals have to do these community health assessments, and they all want to improve population health. I'm not sure what it is, but they will. So it's mostly panels of patients, but that's okay. At least it's more than one patient. So there's an opportunity, I think, for public health and medicine to start to work together in a different way. Whether that's going to, and that involves, will involve some things like data, the ability to use. There are lots of problems with healthcare data, as you know. So, there are reasons why many people in public health, why we do things like national surveys, because there are problems, with data from the healthcare encounter in terms of understanding patterns of population health. But at the same time, I think there are things for which it can be mined that can be very complementary and potentially useful. So I think there's an opportunity. Of course, there are lots of other issues, economic and political issues, that have to do with data sharing and ethical and, privacy issues as well. But it seems like there's a movement in that direction from my perspective. But, others here may have other opinions.
There's one more back here.
So the school is wants to focus on Philadelphia to address population health. That's our mission. My question is, have we considered going into the neighborhoods and asking neighborhoods what they think the need is, or are we just coming up with our own data and our own interests and saying, okay, this will work for this, let's do this? Is there an outreach to the neighborhoods in Philadelphia?
That's a good question. So I can see what it's a loaded question, but it's a good question. No, of course. I think we have to. We have a responsibility as a school to provide data or provide a way to understand data. We have to do that. That's our responsibility as a school. That's why we get paid, right? At the same time, I also there's other information which is not quantitative and is not present in data that we have to get from communities. So I think and sometimes starting with the data is a way to generate that conversation, because people can react to it and can say, oh no, that's not right. That's not what we experience here. Or they can say, oh yeah, that's right, but you also have to look at this. So I think that we have to do both things.
Necessarily say go door to door, but connect with the
Yeah.
community organizations
Of course,
within
yeah.
that neighborhood
Yeah, and
that deals with them on a regular basis,
Yeah.
and they relate.
Yeah, and I I think there are many folks in the school who are doing that or trying to do that.
We have one more question in the back. Yes, you.
So, I work for Drexel, I'm also a student at Drexel. I know you just said that our responsibility is data and getting numbers pretty much. What responsibility do we have outside of that? Once we have the numbers, once we have the data, what does Drexel feel is its responsibility? Do we wash our hands of it once we get it? Do we just pass it off and say, now you have it, do what you want with it, and then we kind of move on to our next research project, which gets us more acclaim? And what do we do next with it? And what responsibility do we feel like we have? What are we supposed to do?
Well, what do you think?
I mean, I think that from one perspective, just living in the neighborhood, I live at 42nd and Lancaster, so I see what Drexel is doing in the neighborhood, I see how they're trying to change it. I just wonder how far that's going to go. Right now, there's a clear dividing line as you go up Lancaster Avenue. You get to 38th, it starts to change, you get to 40th Street, and it's totally different. I mean, it's almost as if the other side of 40th Street is totally forgotten, like nobody's really doing anything really about it or caring. I don't know what steps can be taken. I mean, at a certain level, it starts to be, well, how much money do we have? What resources can we put here? What capacity do we have? And I don't know how that's being allowed already, and what plans there are to allow that.
No, I mean, I think you raise a very important point. I mean, I'll just say a couple of things in reaction to it. I think, public health is not just about data, it's about data for action and for transformation. And that's what attracted me to public health. So it's not just about, it's science, but it's that science for the application for the change, right? And so we're right in the middle of that. And so we do have a responsibility to think about the implications of the information that we have and to work with others to begin to act on it. At least I think so. I mean, your question is also more general about the social responsibility of universities, and I think it's a very good question. And I think lots of people are thinking about it, and I think universities, my personal opinion is that they do have a social responsibility. But that's a broader discussion that goes beyond public health, of course.
I just want to follow on that question. You're putting the responsibility on the institution, but what can you do within yourself to bring a change? That you have to get it out. It's not like asking an outside party, get a change for me. People have to bring a change on their own also. They have to work on their own.
Thank you all very much for being here with us today. Thank you, Dr. Diez.
Thank you very much.
You're welcome. Nice to see you.
Nice to see you. Thank
How
you
are
for the
you?
invitation.
Thanks for coming.
I think you're coming perilously close. Perilously close.